everyone. I'm one of the interventional fellows at University Hospitals in Cleveland. It is actually an honor and a pleasure to be here and present this case. This is a case of a 65-year-old female that got transferred to us from an outside hospital with acute limb ischemia. So going back to her history, she's 65, she's got run-of-the-mill Northeast Ohio risk factors, COPD, diabetic, dyslipidemic, peripheral vascular disease. She did have bilateral iliac stents placed in November 2017. She presented with lower extremity pain to one of the outside hospital, and from there she was referred to us. Her vitals on arrival, she's pretty much stable. Exam is negative. She does have 2+ femoral pulses when she got here, absent distal pulses. They were dopplerable though. Her medications include aspirin, lisinopril, albuterol, and heparin and Plavix that were initiated upon transfer. She currently still smokes. She's a 45-year-old smoker, and her labs are pretty much normal. So outside hospital angiogram right before the transfer, when she presented over there, they went left common femoral access. The first angiogram, there's not much flow up in the aorta. The stents may be occluded, maybe unclear what's happening in there. They did do balloon angioplasty, and these were their final results. So she actually was clinically doing okay. Her pain improved on heparin drip, but with this final picture, it was still unclear what's happening. Is there a dissection that happened in the distal aorta that was precluding distal flow, or is there a thrombosis in the existing stents? So she got transferred to us. Her ABIs, when she was in our hospital, waveform is monophasic down in the ankles, severely decreased ABIs, 0.26, 0.31, flat lines at the toes, and you really, really don't need a cardiologist to tell you that flat lines is a bad sign. So where do we go from there? What is the plan? We entertained a lot of possibilities, having vascular surgery to perform an aortobifemoral bypass. Remember, the patient is on Plavix, thrombolytics, systemic thrombolytics therapy, or even local. Endovascular intervention, which is clearly what we went for, and we'll go over why. So we took her to the cath lab, left common femoral access. This is, by the way, her waveform from the sheath. 28 is the blood pressure. And the first chart that was pretty much concerning, it's similar to their initial picture. There's not much flow going up in the stents or in the distal aorta. So we tried to wire it with a woolly wire, and you see how the woolly is buckling in the stents. And a few things will go on our minds. Is the interaction with the stent struts, or is it with a luminal thrombus, or even maybe is this running behind the stent? Aortogram, we're able to come up with a catheter, and aortogram confirmed that we're actually luminal in there. So we performed, for the sake of time, I'll skip some of the slides, but we performed extensive debulking with mechanical thrombectomy using the 8 French penumbra device, which has the distal separator that's trying to mobilize the thrombus, and the penumbra, the 8 French catheter, suck the thrombus and clot outside. So we did it on the bilaterally. We had a little minor complication here. The separator from this extensive interaction with the stents, we got it dislodged and it got detached, but fortunately we were able to pull it out of the body through the sheath. So we post-dilated with 7O balloons, normal pressures, kissing balloons at normal pressures as well. Just to understand the mechanism of failure for these stents, we thought it's mandatory to perform an IVUS run, and we'll play it and we'll go over it. So this is in the distal aorta here. There's a lot of thrombus in the lumen going down to the bifurcation. There's still thrombus in the stent, but going even more distally, there is a clear undersizing of the stent compared to the proximal common iliac arteries. And here we still see some thrombus distally. So angiogram post-ballooning, these were our final results. And we're not really satisfied with these results. And given that we really now understood what the mechanism of failure of these stents, we decided to deploy APO stents and creating a new carina at the distal aorta, given the findings that we saw in IVUS. So post-dilator with 7O balloons, and these are the final pictures, kind of different than the initial image that we showed. So this is the pressure transduced from bilateral femoral sheath, and we see a good dicrotic notch. And actually, it was very comparable to the upper extremities blood pressure that we were able to measure. ABI's pre-discharge, pretty much up now, 0.85 and 0.95, and the waveform themselves, triphasic waveform, even the PVR waveforms, there is sharp upstroke and it goes back to the baseline. So the patient was discharged with a closer follow-up on her medication, on a bunch of medication that were new to her. She got discharged on aspirin, Plavix, and Coumadin that she will be on for 1 month, and subsequently we'll just continue the aspirin, continue the Plavix for a total of a year, then switch back to aspirin and Coumadin. So there's the lesson learned from this case, a lot of teaching points, especially for fellows in training. Having a vascular team, early conversations with the vascular surgeons, try to avoid unnecessary delays in the patient care. This case was a late evening activation. When patients started having worsening lower extremity pain requiring narcotics, we decided to take her straight to the cath lab. Intravascular imaging, I think it's mandatory now to delineate the mechanism of failure and really understand and have the accurate sizing and measurements if you want to put some stents in there. It's 2018, there's no reason or excuse not to do intravascular imaging. Having the right technology around, the penumbra suction catheters, and CVI provides a good arena here to get exposed to the cutting edge technology, and I think we should all be exposed to what's in the field. And a close follow-up afterwards, the patient was seen in clinic, she actually walked into our clinic, that was very rewarding, and we should remember that we're really physicians, focus on risk factor modifications. She was smoking a pack and a half a day, now she's down to 2 cigarettes, and she promised she will stop within the next month or so. Thank you.
Thank you.
I have one question for you. Yeah. So you have a patient who had a distal aortic problem, and a few days later, you have bilateral upper limb, upper thigh, diminished pressure waveforms. And obviously you are thinking about the fact that this is again the reoccurrence of the problem the patient already had, but you guys still chose to get, and Mehdi cannot answer this, but you still chose to get the left groin access. Now, why would you torture yourself and not also get a radial access? Because, you know, the stents are proximally occluded, and it would be much easier to think about it.
Our very high suspicions were that this will be thrombus, and we were anticipating we'll be using bulky devices, mechanical suction devices. We may need 8 French, this was an 8 French. And at some point, you can maybe use Inari devices, which is a 22 French. Doing all of this radially or brachial will be very challenging. So we went with our gut feeling that we're going to be needing large gizmos to get over this.
Okay.
Fantastic.
Thank you.
Thank you so much. Thank you.